Hello and welcome back to the channel. Your GP may send out a letter informing you when your estimated GFR is 59 or lower. Usually this indicates that you would be added to the GP register as having chronic kidney disease. This is part of the quality outcomes framework to facilitate the early identification of CKD. This important identification not only allows appropriate measures to be taken to slow or prevent the progression to more serious CKD, but also to highlight and manage the key associated risks related to patient safety and avoidable harm. What is chronic kidney disease? Chronic kidney disease, or CKD, is a common disease defined by persistent urinary abnormalities, evidenced by the presence of blood and/or protein in urine, structural renal abnormalities, or impaired excretory renal function, which is a decline in the kidney's ability to remove waste products, excess fluids, and toxins from the blood through urine. How to measure CKD? Your GP would request a kidney function test and urine albumin to creatinine ratio, both of which provide two indicators of CKD that are useful for the classification and risk stratification of chronic kidney disease, and it's also used to monitor progression to end-stage renal disease. This chart helps classify chronic kidney disease risk by looking at two key kidney function markers: estimated glomerular filtration rate and urine albumin to creatinine ratio. Estimated GFR measures how well your kidneys filter waste, while ACR indicates how much protein or albumin is leaking into your urine, a sign of kidney damage. The risk of kidney-related complications increases as eGFR declines and ACR rises. If your GFR is normal, greater than or equal to 90 or only mildly reduced, 60 to 89, and your ACR is low, there's little risk of CKD unless other kidney damage is present. However, as estimated glomerular filtration rate drops into the moderate, G3A to G3B or severe G4 ranges, the risk becomes moderate to very high, especially if ACR is elevated. For those with kidney failure, G5 or estimated GFR of less than 15, the risk is very high across all ACR levels, meaning specialist medical attention is needed. For this reason, a minimum number of yearly monitoring or checks for eGFR and ACR is recommended in patients with CKD because a decline in eGFR is associated with an increased risk of mortality. The risk increases with a faster decline. The new NICE guideline recommends the use of the kidney failure risk equation for adults as a referral criterion for specialist assessment, following its recent validation in a UK cohort. This predicts the 5-year risk of needing renal replacement therapy based on age, sex, eGFR, and urinary ACR, with a referral threshold greater than 5% and is likely to offer greater sensitivity and specificity compared with the eGFR threshold advised in the previous NICE guideline. The hope is that this will lead to earlier referral for those who are at highest risk of CKD progression and reduce the number of referrals of those for whom secondary care opinion adds little value. In adults, certain situations signal a higher risk of serious kidney problems and would need referral criteria for specialist assessment. One red flag is having an ACR of 70 milligrams per millimole or higher unless it's due to diabetes and already well managed. Another is an ACR over 30 milligrams per millimole combined with blood in the urine, hematuria, which could indicate significant kidney damage. A rapid decline in kidney function is also concerning. This includes a sustained drop in eGFR by 25% or more within a year, especially if it leads to a shift to a worse chronic kidney disease stage. Similarly, if eGFR falls by 15 per year or more, it suggests aggressive kidney deterioration that needs investigation. Uncontrolled high blood pressure is another warning sign, particularly if it remains resistant to treatment despite using at least 4 different blood pressure medications at the right doses. Additionally, if a rare or genetic kidney disease is suspected, or if there's a possibility of renal artery stenosis, your GP would refer you for further specialist evaluation. Why is predicting the risk for kidney failure helpful? You may discover that even though you have chronic kidney disease, your risk of reaching kidney failure is actually quite low. In fact, only about 3% of chronic kidney disease patients ever reach that stage. Knowing your risk ahead of time gives you the chance to prepare and take action to keep your kidneys working for longer. And if kidney failure does seem likely within the next 2 to 5 years, early prediction gives you and your GP time to explore your treatment options. What are the common complications of chronic kidney disease? Malnutrition and proteinuria. Good nutrition is important for providing your body with the resources to fight infections, repair body tissue, and build new muscle. Having a more advanced stage of chronic kidney disease increases your risk of problems with your nutritional health and malnourishment, especially for people who are on dialysis. Albumin is an important protein normally found in the blood that serves many roles in the body. These roles include building muscle, repairing tissue, and fighting infection. A low level of albumin in your blood may be caused by not getting enough protein or calories in your diet, especially if you are on hemodialysis. Since albumin is made in the liver, low albumin levels can also be a sign of liver problems. Measuring serum albumin levels can be used to see if you are getting enough nutrients in your diet. Similarly, loss of protein in the urine is also a marker of kidney damage. It's a strong warning sign that chronic kidney disease could progress to end-stage renal failure. To help slow down this progression, ACE inhibitors, or ARBs, have long been recommended for adults with ACR levels of 70 milligrams per millimole or higher, as they've been proven to lower the risk of kidney failure. Now, the latest guidelines extend these recommendations beyond adults. They now include children and young people with chronic kidney disease who have an ACR greater than or equal to 70 milligrams per millimole. Additionally, they emphasize the importance of using these medications for anyone with chronic kidney disease and diabetes type 1 or 2 when their ACR is 3 milligrams per millimole or higher, as even mild protein leakage can indicate early kidney damage in diabetes. Anemia. The kidneys play a very active role in helping your body make red blood cells. Also, people living with advanced chronic kidney disease can have problems absorbing iron from food. They are also at high risk for repeated blood loss from frequent blood tests and during dialysis. This makes the kidneys try to make even more red blood cells when they are having trouble keeping up in the first place. So having a more advanced stage of chronic kidney disease increases your risk of anemia, especially for people who are on dialysis. Mineral and bone disorder. Your kidneys play a very active role in balancing the ingredients needed for healthy bones: calcium, phosphorus, and vitamin D. In more advanced stages of chronic kidney disease, your kidneys may have a hard time activating vitamin D, which is needed to absorb calcium from your food and removing extra phosphorus from the blood. This increases your risk of having calcium and phosphorus levels that are out of balance, also known as secondary hyperparathyroidism. Without close monitoring and treatment, this can cause chronic kidney disease-related bone disease, also known as CKD mineral and bone disorder. Cardiovascular disease. People living with chronic kidney disease are at an increased risk of having cardiovascular disease, which includes heart attack or stroke. This is especially true if you have an advanced stage of CKD and/or if you have albuminuria. Your risk of cardiovascular disease, that is, heart attack or stroke, is increased even more if you also have high cholesterol and/or hypertension. Treatment targets for hypertension remain similar to the general hypertension guidelines. Diabetes. One of the major causes of chronic kidney disease is diabetes. Two of the most common tests used to diagnose and monitor diabetes are the hemoglobin A1C and serum, or blood, glucose level. NICE now recommends SGLT2 inhibitors for adults with chronic kidney disease and type 2 diabetes, alongside an ARB or ACE inhibitor if their ACR is above 30 milligrams per millimole and they meet the required criteria, such as having an eGFR above 15 for dapagliflozin. What makes this recommendation so exciting for patients and prescribers is that SGLT2 inhibitors appear to slow kidney function decline, which is a major breakthrough in CKD treatment. While real-world experience with these medications in CKD is still growing, they have the potential to become a standard part of therapy in the near future. It is a life-changing event developing end-stage kidney disease that requires dialysis or a kidney transplant. That is why in primary care the emphasis is on following a healthy lifestyle, including a healthy diet and hydration, exercise, keeping a healthy weight, and quitting alcohol and smoking. These preventive measures are essential to keep your kidneys working for longer. Following a healthy lifestyle can lessen the chances of more problems, including heart disease, high blood pressure, and high cholesterol. Reach out to your primary care clinician if you are in doubt or want to learn more about living with chronic kidney disease. I hope you found this helpful. Don't forget to like, share, and subscribe to the channel for more educational videos.